advances. Inviting you, Dr. Jefferson.
Yeah, I would like to thank the organizers for this opportunity. So I'm here to share a few words about asthma COPD overlap. Um, we all know asthma and COPD have a lot of similarities. They're both airway diseases. They cause airflow obstruction. They cause shortness of breath. They both have chronic inflammation of the respiratory mucosa. But the similarity ends there, and they have different risk factors. They have different clinical outcomes, different pathogenesis, and different responses to treatment. We all know asthma is predominantly or largely an atopy-driven disease, has an early onset in life. However, there are certain subgroups or phenotypes which have late onset and without atopy also. But predominantly asthma, the first thing that comes to our mind is atopy and childhood onset. Whereas COPD is usually adult onset and or exposure related. It could be a particulate matter, cigarette smoke, or even biomass fuel exposure. Asthma by nature usually has a variable airway limitation. A chronic asthmatic sometimes may not showcase that, but usually it is a variable airway limitation. It means sometimes there is no obstruction in the spirometry, sometimes there is. COPD, on the other hand, usually has a fixed airway limitation. You'll always see obstruction in the spirometry. The inflammation is predominantly eosinophilic in asthma, whereas in COPD, it's predominantly neutrophilic. In asthma, the involvement is usually medium-sized airway, and now we have more advanced equipment which showcases that asthma can involve even small airways, whereas in COPD, it is usually the small airways and lung parenchyma. So although there are similarities, both have their unique characters. But then comes the real life scenario when you sit in your OPD and you see you can't really put all patients with obstructive airway disease in both these categories. There may be patients with asthma, but the disease may be behaving like COPD. They may have fixed obstruction in their spirometry. They may have persistent cough. Despite inhaled corticosteroids, their symptoms may not be controlled. On the other hand, you will have COPD patients who have an eosinophilic inflammation, responding better to inhalers, better symptom control, etc. I'm sorry, yeah. So the whole problem of a disease overlap or a similarity that has over the period of time have gave forth to theories such as the Dutch hypothesis and the British hypothesis. So there was one school of thought which said asthma and COPD, they are manifestation of the same disease process based on what the person is exposed to. If it's a biological protein, an allergen, and the inflammation is secondary to that, it behaves like an asthma. And if it is a particulate matter exposure, a non-biological substance, it behaves like COPD. The inflammation behaves different. That's the Dutch hypothesis. So in essence, they say asthma is one end of the spectrum and COPD is in the other end of the spectrum. Then the British hypothesis, a different group of people who said, no, it's not like that. They're really unique in themselves. The genetic predisposition is different. So some patients, they have a genetic predisposition to develop atopy, and then atopy leads to hypersensitivity reactions, leading to the manifestation of allergic diseases, starting with allergic rhinitis and then going on to develop asthma. But COPD is completely different, where smoking and biomass fuel exposure and particulate matter leads to disease. So that's the British hypothesis. Whatever said and done, in your OPD, you will see the spectrum of diseases. You will see COPD, very classic COPD. You will see very classic asthma. And then there will be a group of patients right there in the middle. Half of you will think it is asthma and half of you will think it is COPD. And it is not uncommon to see in OP charts, if you review 10 years, at some point it was called asthma, and then suddenly some consultant called it COPD, and then you're not sure what it is. And to add confusion to this, you have proper COPD with eosinophilic inflammation and proper asthma with neutrophilic inflammation. So what is this ACO or asthma COPD overlap? So right now, the current concept is it is just a descriptor. It is not really a unique disease. It's a descriptor for patients whom we often see who comprise, a heterogeneous group of diseases belonging to the obstructive airway disease and not necessarily a single disease entity. So in 2014, when the global guidelines for both asthma and COPD, they came together and issued a document saying that, see, now we have to be more aware of what is known as this asthma COPD overlap syndrome. So they initially described it as a unique entity. But over the period of time, when more and more research was done and better understanding of this concept came to being, they realized it's mere coexistence of two diseases. It's possible that someone can have both asthma and COPD at the same time. So it is this coexistence we describe as asthma COPD overlap, and it is not by itself a unique disease entity. So they are different disorders. Asthma and COPD are different disorders. They share some common treatable traits and clinical features. The eosinophilia can be present in both groups. Even COPD can have reversibility at times. So don't go just by spirometry evidence. So a concurrent diagnosis of asthma in a COPD, the patient should be treated based on asthma guidelines with specific pharmacological and other approaches which we consider for a COPD patient. So in essence, it's a description of a collection of clinical features rather than a single disease entity. And the most important thing is recognition of these patients in our clinical practices. It has its own problems. Why are these labels very important? See, your COPD patients, the predominant treatment is going to be bronchodilation, not inhaled steroids. And in this group of patients, if you're going to give moderate to high dose inhaled corticosteroids, they themselves can lead to pneumonias or lower respiratory tract infections, thereby contributing to exacerbations, the very thing you want to prevent in a COPD patient. Whereas if the diagnosis is actually predominantly asthma and you think it is an asthma COPD overlap or a COPD disease, you withhold inhaled steroids from them, they are again likely to have a progressive disease with more exacerbations. So this is where precision medicine has its role, and asthma is often considered as the ideal disease where you can develop precision medicine because it's very heterogeneous. Asthma is heterogeneous, COPD is heterogeneous, and there is an overlap of patients who have symptoms and clinical features of both the diseases. So how common is it? So first I would like to summarize a systematic review done in 2020 where there is a problem with asthma COPD overlap in that there are several proposed criteria. Nobody really knows, or rather, there is no single accepted global criteria where you use this criteria and diagnose asthma COPD overlap, because the idea of asthma COPD overlap is different for different people. So there are so many studies with various criteria, which I will be listing later. Hence, true meta-analysis was very difficult. It was a very heterogeneous study group. Despite all that limitations, the true prevalence of asthma COPD overlap in the community was 2%, almost as high as asthma in some countries. Among those who have an asthma diagnosis, around 26% people actually have an overlap with COPD. Likewise, among those with COPD diagnosis, about 30% of them have an overlap of asthma. This could be missed if you're not aware of this overlap concept. So we did a study in CMC. We interviewed about 713 asthma patients and close to 160 COPD patients who were diagnosed earlier and were in regular follow-up in the pulmonary medicine department. So consecutive patients over a period of 3 months were taken, interviewed, and their diagnosis readjusted. So among 713 asthma labels, people who were in regular follow-up in the pulmonary medicine OPD, only 95.5% actually had confirmed asthma. So we used a diagnostic tool proposed by the GINA and the GOLD guidelines in 2015. That's what we used, which I will be mentioning a little later. And about 1.7% were actually COPD who were misdiagnosed as asthma. It's understandable because the disease is very similar. And about 2.8% actually had an asthma COPD overlap. So in addition to the 12 people who had proper COPD, there were about 20 others who had features of both asthma and COPD. Likewise, in about 115 pure COPD patients without bronchiectasis, without post-TB sequelae, without fibrosis, pure COPD patients, we found that about 24.8% were actually asthma, not even COPD, they were asthma. And about 17% were actually asthma COPD overlap. This happens because a lot of these long-standing asthmatics, their spirometry won't show reversibility. The disease might behave like COPD, and it's very easy to mislabel them as COPD. Well, they are actually chronic asthma with fixed airway. So this again is understandable. Again, showing how difficult it is in real life practice to differentiate them in one visit or two visits. These diagnostic tags have to be revised and reviewed in every OPD visit and understand how the disease is behaving. A right tag is possible only then, not in just two OPDs. So why is it such a big thing? So what if they have both asthma and COPD? Most of them anyway go on a combination of inhaled corticosteroids and long-acting beta agonist. Why are we so concerned about this echo term? So in our study, we found that they are more severe. Some of these disease outcomes and parameters for asthma COPD overlap was more severe than asthma, while not as severe as COPD. That trend was found across multiple outcomes. So 6-minute walk test desaturation was present in about 12% of asthma COPD overlap patients. The distance saturation product was again lower than asthma, but not as low as COPD. So in essence, asthma COPD overlap behaves worse than COPD, but may not be as worse as, not as better than asthma. So it's somewhere in between asthma and COPD. And there is a component of eosinophilic inflammation as seen in peripheral eosinophilia, which is more than what it is seen in COPD. The number of exacerbations per 100 patient years among confirmed cases of asthma, COPD, and echo. Again, echo had more than asthma, but not as high as COPD. And ICU admissions are again more in echo compared to asthma. NIV ventilator need is more in asthma COPD overlap compared to asthma. So the importance of identifying this tag is that most asthmatic patients may do okay on PR and inhalers, whereas your asthma COPD overlap patients, if you treat them like asthma and you don't follow up regularly, they are not on regular treatment, they're likely to have poorer outcomes. And while not as bad as COPD, they are approaching COPD in most of these outcomes. So it's very important to figure out if your asthmatic has a COPD component. The vice versa is true. If you predominantly label someone as COPD, he was a smoker, 45 years of age, comes with symptoms, and it's pretty easy to label as COPD, right? But what if they also have an asthma component? Because in COPD right now, most of the groups we treat with only bronchodilators. Inhaled corticosteroids we only give if there are more than 2 exacerbations or if there is an eosinophilic inflammation identified. So that's why it's very important to get the diagnostic tags right. And I'm just summarizing just to showcase you how many different criteria have existed since 2009. And they're very extensive, but no, they could not come to a consensus. And this is the combined syndromic approach tool proposed by Gina and Gold in 2015. By the way, they have moved on from this. This is the tool that we used for our study, where they classified 11 important points that favored asthma and a few points that favored COPD. Someone who has both, could be considered as asthma COPD overlap. So based on the criteria they used, the prevalence of echo that was reported in the same population or a different population varied. So that's why there was no uniform consensus as to what defines asthma COPD overlap. Finally, they settled. This is the latest GINA 2024 guidelines. They just settled saying you clinically decide. So clinically, there are these features which are highly likely to be asthma, and there are certain features which are highly likely to be COPD. If somebody has predominant of both symptoms, if they have a mixture of both symptoms, it's likely that they have an asthma COPD overlap, but they should definitely have an expiratory airflow limitation to diagnose asthma COPD overlap, like COPD. So if you think it is likely to be asthma, make sure you give inhaled corticosteroids and don't just stop with I'm sorry, long-acting beta agonist or LAMA. Anyway, let's come to the diagnosis part. Like I said, diagnosis is clinical. If the nature and pattern of respiratory symptoms is both representative of asthma and COPD, be on alert and please consider asthma COPD overlap. So if there is a history of asthma diagnosis or a COPD diagnosis before the patient comes to you and you feel otherwise, then there's a good chance this patient might have asthma COPD overlap. Exposure history is very important. And if you know, the most common cause for COPD is not smoking, it's biomass fuel exposure. Now, of late, particulate matter exposure, pollution are being more and more identified as a cause for COPD in India. So don't just stop with smoking history. Please do ask history about indoor pollution, even history about mosquito coils. A lot of us don't use mosquito coils, but some of our patients still do. It's said that one mosquito coil churns out particulate matter equal to smoking 300 cigarettes. So there are households which use the classics, anti-mosquito coil repellents. So indoor pollution history is very important. And then you have to do your spirometry. You have to have a persistent airflow limitation or obstruction spiro before making a diagnosis of asthma COPD overlap. And a reduced post-bronchodilator FE1 FEC ratio is needed, and most often the cutoff is 0.7. In some cases, they encourage using the lower limit of normal, but by and large, most guidelines are still sticking to post-bronchodilator FE1 FEC less than 0.7. And there have to be a significant reversibility of your post-expiratory volume in 1 second post-bronchodilator with 12% and 200 ml reversibility. Now, there are certain tools, like I said, when you see a group of patients, they can be overlapping symptoms between them. So whether they are asthma or neutrophilic asthma or asthma COPD overlap or eosinophilic COPD or COPD, it can be very confusing. But if you go at the phenotypic level, the best tool we have right now in CMC is sputum eosinophil count. Our pathology department does it. It's quite expensive, not for your routine patient, but if you have a patient whom you're not sure how the inflammation is, you can do that. If your sputum eosinophils count is more than 2%, that means the inflammation in the lung is eosinophilic. If the neutrophil count is more than 61% in the sputum, that's a neutrophilic inflammation. And if both are present, it's mixed cellular. If neither are present, it's paucicellular. That's the kind of lung inflammation we deal with. Finally, we know it's an eosinophilic inflammation. It is going to respond to ICS. Whether you tag it as asthma or COPD or asthma COPD overlap, if the inflammation is eosinophilic, they will respond to eosinophils. If the inflammation is neutrophilic, they are not going to respond to inhaled corticosteroids. So you may have to give additional medicines. And while this is not possible for everyone, we have blood eosinophils and FeNO, fractional exhale nitric oxide. Both of them have a moderate correlation with sputum eosinophils, which is still considered as the reference standard. And generally, we have the concept of doing IgE for everyone and then say, yeah, this person is atopic, so most likely it is asthma. So that is to be discouraged because total IgE can be elevated in several other conditions. I would encourage you to consider skin prick test for allergy or Fadiotope, which is a blood test, which is almost cost the same as an IgE. Both these, if present, says that the person is truly sensitized to certain allergens and have allergy. So allergic asthma. And be careful that COPD patients can also have sensitization. So total IgE is not really a very useful tool. So when it comes to general measures, we take these from the COPD guidelines because they have overlap of asthma and COPD, smoking cessation, vaccination, and allergen avoidance from asthma, if where possible. Inhaler technique has to be corrected, and pulmonary rehabilitation. They all help your asthma COPD overlap. Final pharmacological management is very simple. If the disease is behaving like asthma, make sure they are on ICS. All asthma COPD overlap patients should be on inhaled corticosteroids. Adding LABA or LAMA is based on how much the symptoms are able to be controlled with only ICS and LABA. You can add a LAMA agent like tiotropium if you think that the disease is not fully controlled with the ICS LABA combination. So in essence, make sure you treat it as asthma. If the symptom control is not adequate, you can add the COPD treatment as well. Now there are more and more evidence of biologicals. I think dupilumab is slowly getting into the COPD guidelines if there is an eosinophilic component in the inflammation, which is usually reserved for asthma. So there are more studies now, and tezepelumab is coming in a big way. It's a biological that acts upstream, irrespective of what the inflammation is found in the lungs. It's not yet there in India, but is soon to be expected. So there is a role for biological therapy, but not for everyone, selected group of patients. So in summary, asthma COPD overlap is a description. It's not a unique disease entity. It's extremely heterogeneous. It can be an asthma dominant asthma COPD overlap or a COPD dominant asthma COPD overlap. Make sure that all patients are on inhaled corticosteroids. And classically, most of our CHAD patients or poor patients, they try to buy only Asthalin or Tiowa. Most of the time it works for COPD, but not for asthma COPD overlap. So don't just look at symptom control, also look at the number of exacerbations every year, overall disease progression, etc. Yeah. Thank you.